Hello, everyone. Bienvenidos a Vancouver. Welcome to Vancouver. I'm actually not Dr. Lehman. I'm Dr. Avina. I'm a rheumatologist trained in Mexico and that came to do a PhD here in Vancouver, and now I'm continuing my career here. And we're just going to present what are the disparities that we've seen and encounter in the Aboriginal community in Canada. And I'm just going to give the context that we think will explain some of the limitations that had led to this after the wonderful presentation that we had by you. It was amazing. And we were worried for the timing, but after what you do with your resources in Haiti, I think we shouldn't be worried about it. Anyway, next slide. Well, this is I hope you can see it. This is a distribution of the population of the Indigenous people in Canada. It's around 1 million across the country, and the dots represent the population samples by Statistics Canada. The smaller the dot is, the less the group is usually, and the darker. The darker dots represents less than 500 people living in that community, and the lighter and larger dots represent communities with 2,000 or above 2,000. So this is across the country and usually in small communities, and this is one of the reasons why some of the gaps can be explained. Two events that also I think will be useful to know or to let you know, which surprised me, is that there has been a chronic history of abuse and racism in Canada with the Aboriginal community. And this is something that actually it matters the way you approach to closing the gaps, and not only in clinical care, but in research. In the 19th century, the Canadian government started what they called the aggressive assimilation of the new culture. What they tried to produce was a generation of English-speaking Indians that will become the ways of the civilized life. So they removed in total 150,000 children across Canada from their parents, so they acculturize them. And that created a big problem that we're still paying for. At the end of the day, all these conditions led to mistrust on the Western culture because they live in substandard conditions and endure physical, emotional, and sexual abuse. So, another case why research has become a very big problem and difficult to approach is in 1982 from 1995, a researcher here in BC performed the biggest genetic study in Aboriginal communities. He collected 883 samples of blood across families in Vancouver Island, trying to disentangle the genetics of arthritis. The problem was that the PI never went back to the community. He was moved to the USA, and he took the samples. And then he also moved to the UK, and the samples were taken with them. And a lot of studies that were published that were not related to the original research. At the end of the day, the community were very upset, and they didn't believe again in the research. So nowadays, this is one of the reasons that we think we have to consider when we're trying to approach. And I'm going to pass to Eileen.
Thank you. My name is Alan Lehman. I'm a health psychology researcher here in Vancouver, working at the Arthritis Research Center of Canada. And I'm going to discuss just briefly some of the challenges and successes our team has had in working with Indigenous peoples in Canada, specifically First Nations people on Vancouver Island. One of the key challenges, and Dr. Nickerson alluded to this so well this morning in the discussion in Haiti, is really establishing the relationships with people locally. And given the context that Antonio just presented, it really can take quite a bit of time to develop the mutual trust and respect for each other, both understanding the culture and how people are approaching things, having a sense of cultural humility, as we heard this morning, as well as understanding some of the historical conditions that have happened in the past, helps one better develop and maintain the relationships. So in our experiences, quite a bit of time is spent explaining sort of the process of research, as well as us understanding the community's needs and desires and perhaps their previous experiences with researchers, health professionals, and the government. One of the challenges, of course, you have to obtain individuals' consent, but one of the unique challenges is obtaining the community's consent. So in our experiences, this means the consent from the band chiefs, the band council, and elders. And I just mentioned this because it takes quite a bit of extra time to ensure there aren't any misunderstandings in the approaches to doing research. All of this is, of course, added time and money, particularly given the geographic diversity of some of the locations of the communities. This is a map of Vancouver Island. Sorry, I don't have a pointer. The communities we're working with are all the way from the tip of Vancouver Island in the north down the inner island halfway down. Just to give a bit of context, if one was to take a ferry ride from Vancouver, that would be about 2 hours, then up to a 2.5, 3 hour drive to get to some of the communities. Now, I've just briefly touched on some of the challenges, but we've had quite a number of successes in the last 5 years with our relationships in a true partnership with the community. And really fundamental to that has been doing community-based research. And by this, I mean the community, the individuals, the leaders, the band council, has really driven the research agenda, as opposed to the researchers dropping in with a very perhaps intriguing question, but one that might potentially not be relevant to the community. In our experience, before we even started the relationship, the community had conducted their own surveys and identified SLE and other rheumatic conditions as their #1 priority chronic health illness concern. So from a researcher perspective, there was already quite a bit of empowerment in the community and desire to do something about that to better improve their care. One of the things that has worked quite effectively for us, albeit taking quite a bit of time and resources, is frequent ongoing community consultation. And by this I mean going in at the beginning before you do the research. You might have a preliminary research plan, but sharing that with the community, but then listening and obtaining their input. In our case, this has helped refine the research questions and also helped refine the methods we've adopted to better understand the prevalence of SLE and other rheumatic conditions in the community, as well as arthritis-related disability and access to care. This has helped, in our experience, establish amazing community buy-in. And in our study of the prevalence of SLE and other arthritis conditions, we had a 75% response rate, which, at least in our experiences, was absolutely amazing. And in doing all of this, as Dr. Nickerson alluded to this earlier in his opening talk, is the need to continue to build capacity for research and care in the communities. And by this, we hired people locally, provided extra training to enhance their already existing skill sets, as well as worked with local health professionals to provide more education regarding arthritis diagnosis, assessment, and care. Thank you.
So I'm Christine Peschken, I'm from Winnipeg, and so we wanted to talk a little bit about the interrelationship between research and access to care. Certainly in our area, I mean, the Canadian and American Indigenous populations are extremely heterogeneous, both culturally and geographically and likely genetically, and certainly with respect to disease susceptibility. But in Canada, we certainly have identified at least twice the prevalence of lupus. And you know, we're a little bit different from some of the previous speakers in that we're all covered by the same universal publicly funded healthcare system, but we still have care gaps and outcome gaps for our First Nations people that we have identified that they have overall a lot worse outcomes in terms of higher damage, most particularly a very high rate of progression to renal failure, and a lot of comorbidity, poor quality of life, and a higher mortality rate. And most of that stems from not getting them into care. There are delays in accessing physicians, and even once they do see somebody, they're not followed up as often and as much. And there's a variety of reasons we've discovered for that, and a lot that we still don't understand. We have become aware there are cultural differences in attitudes to health. We don't really have a good understanding why a First Nations person chooses to access health care or not, and we need a better understanding there. There are occasional language barriers, not so much with our First Nation, with the lupus patients, because it's a younger population. The mistrust that Antonio alluded to is not just a research issue, but it's also a healthcare issue, that there is a widespread mistrust of healthcare providers, either due to previous personal or cultural experiences of outright racism, or simply because of a perception of not receiving needed help, so they simply don't come or don't come back. And I think part of that, they particularly won't come or won't come back because it's such a production to get there. If you look at the scale on the bottom of the map, this is, I'm from Winnipeg. Without a pointer, you can see it there towards the south of the green area. That's where all the docks and the specialists are. We cover an area that is the size, several times the size of most European countries, but it's a relatively small population. The total population is about 1.4 million, about 200,000 or so of those are Indigenous. And so we're talking about patients traveling hundreds and thousands of miles to come and see us. That's a setup for not coming to see us, and in fact, that's what happens. So in addition to the geography, we talk a lot about the team-based approach that is ideal for chronic diseases like lupus. Well, there is no team. I mean, there's usually, for most of our First Nations people, there's not even an on-site physician. There's someone who may fly in once a month, or usually there's just an understaffed nursing station. There's no allied health, there's no social work, there's no psychological support, there's nothing very much. And that really complicates our care a lot. Now, there are a few things that we have done that help. Outreach clinics work really well. We have a couple of outreach clinics that we run in two of the larger First Nations communities, and those have provided a huge benefit in terms of care, and that has also been combined with our research agenda, and we've had some very successful research projects. But there's only 12 of us in terms of rheumatologists. We simply can't go to all those many hundreds of communities. So the geography again there, I mean, outreach clinics are not the answer to everything. Education sessions are also helpful, and that's educating the health coordinators for the communities, and we've done a lot of that as well in order to help them know when to send someone down, when to call for help. But there's a very high staff turnover, and so that's something that sort of has a limited time limit. We have to keep doing that over and over again. And we do try to prioritize referrals. Our center, anybody who is Aboriginal gets a higher priority. Again, that is only of a limited benefit. Ultimately, I have to say our healthcare system does not work for this disease in this setting. And so making it work, finding a healthcare delivery system that works has to be part of our research agenda. And again, as Alan and everyone else has said, this has to be community driven. We can't tell the First Nations communities what works. We have to work with them so they can tell us what will work and what might work and what is culturally acceptable to them. And that will improve the care and also inform our research agenda. Thank you.
I wonder if Dr. Singh Kolbai or Professor Singh Kolbai is coming up, if there's a question for this group. I think they identified a lot of issues. Oh, go ahead.
So, given that medical care is federally sponsored, how does the Canadian federal government justify that disparity?
I don't think they can justify it. I mean, this is an ongoing political debate in Canada all the time, and we don't know how to make it work. There's a lot of initiatives to try and make it work because simply throwing money at it hasn't worked. And so, as I said, we need to actually have a research agenda around improving the care delivery, and there is no formal mechanism that I'm aware of.
But they're not ignoring it, it sounds like. They're addressing it, trying to address it.
Depends on who you ask. Yes, no, they're not ignoring it, no.
Just a comment, I think you did a good job of actually diagnosing some of the barriers to care, which is as important as diagnosing the actual clinical condition, which I think ultimately, if you don't do that, you're not going to be able to get the clinical results that you need and want. Thank you.